Okay, so we should be live on Facebook right now. If you're out there, if you can confirm that you could see everything well. And why don't I? All right, perfect. So good morning, good afternoon, good evening, wherever you are. We would like to take this opportunity to welcome you to our conversation on mental health awareness. This is an extremely important topic. My name is I'm Dr. Akwi Asenbang, interventional gastroenterologist with Brown University. I'm the co-founder and board president of the Pan-African Organization for Health, Education, and Research. Happy to be here with you today. Our moderator for this morning is Ms. Anya Avis Nobuth, who is a medical student at Lusaka Apex Medical University in Zambia. And our guest speaker today is Professor Soraya Sadat. We are absolutely grateful for her time. We are looking forward to this conversation. I will now turn my mic off, turn off my video, and Hannah will go over, Anya, sorry, will go over some housekeeping rules. We do have Hannah in the background, who's our Poor Hair volunteer, but Anya will go over some housekeeping rules, and then we'll go from there. Anya, it is over to you.
Thank you, Dr. Akwi. Hi, everyone. I'm Anya. So I'm just going to go through some housekeeping rules. Just for everyone to know, this webinar will be recorded. You guys will be in a listen-only mode, but please feel free to ask some questions in our question and answer box at the bottom. And if there's any comments, please use the chat function. Please also feel free to just go and have a bathroom break, take some tea, take some coffee, and just come enjoy, and you don't have to let us know. And we hope that you enjoy this forum. So we're very privileged today to have Professor Soraya Sadat with us. So Professor Soraya Sadat has an amazing curriculum already. So just looking, I'm not sure how many people read the bio, so I'll just do a brief introduction. So Professor is a distinguished professor of psychiatry and the executive head of department of psychiatry at Stellenbosch University. She holds the South African Research Chair in Post-Traumatic Stress Disorder, which is funded by the Department of Science and Technology and the National Research Foundation. She's been the recipient of several awards, including the World Federation of Society of Biological Psychiatry Fellowship, the Ludwig Institute Fellowship Award in Psychiatry, an MRC Mid-Career Award, Research Fellowship from the University of California, San Diego, the Anxiety Disorders Association of American Career Development Award, the Humboldt Research Award in memory of Neville Alexander, the Chancellor's Award for Research from Stellenbosch University, and an MRC Gold Merit Award. Wow, Professor Sadat, you're quite accomplished. She has more than 20 years of clinical, epidemiological, and basic neuroscience research experiences as a psychiatrist working in the field of traumatic stress and anxiety, and has existing collaborative research projects with colleagues in Europe, the US, and several African countries. She's also been involved in NeuroAIDS research for 20 years and directs a number of research programs and mentors in master's, doctors, and postdoctoral students. She's experienced in research ethics and is currently a member of the Stellenbosch University Senate Research Ethics Committee and a board member of the International Society of Traumatic Stress Studies. She has also published an astounding 400 peer-reviewed journal manuscripts and has co-edited 4 books. So it really is an honor. Thank you so much for taking the time to be with us today. So Professor Sadat, let's jump straight into it. What is mental health?
Well, mental health is a state of both physical and emotional well-being. It is important to think about mental health in the month of October because it's Mental Health Awareness Month. And the theme for this year's mental health awareness is mental health for all, greater investment, greater access. So in thinking about mental health, poor mental health is costly, and it costs the world's economy trillions of dollars. And this is in contrast to what the African countries on the continent actually spend on mental health in terms of their health budgets. So mental health is an integral part of overall health, and there is no health without mental health. And so it's for that reason that the promotion and protection and restoration of mental health is a vital concern, not only to us as individuals, but if we think about communities and societies around the world. So essentially, it's a state of well-being, and it's a state of well-being that allows us as individuals to cope with our life stresses, our daily life stresses, and to function productively. And this is a time, during the COVID-19 pandemic, where I think many of us have had to look inward and think about the daily life stresses that we're experiencing and how best to navigate them. So there are a number of domains of good mental health, like mental health literacy is one. Having good social skills is another. Being able to manage stress or self-management strategies is another. As I've said, mental health is integrally linked to physical health. So physical health is another domain of good mental health. The meaning of life, the quality of life, the attitudes that we have towards people with mental disorders is also part of good mental health. Then our cognitive abilities, our academic and work functions, the way we manage our emotions and our behavior. Those are all core domains of what constitutes good mental health.
Okay, wonderful. So it is quite a broad aspect, and I think this makes it equally as important as anything else within the medical field. So the process, or I think many medical students know the different routes to take to become a specialist. So can you tell us a little bit about the training for psychiatry? What are our options, and specifically within South Africa and any other region in Africa, how would one go about becoming a psychiatrist?
So psychiatrists are medical specialists in the same way that you have surgeons and pediatricians and internists and obstetricians, gynecologists who are also medical specialists. In South Africa, to become a psychiatrist, it takes 13 years of training. And so you complete a 6-year medicine undergraduate program. You become a doctor. You then complete 2 years of internship in a public hospital. And upon completion of your internship, you undertake 1 year of community service. And that's also done in a public hospital. And then you can enter into a psychiatry registrar or residency program. And that program is a 4-year program. In South Africa, there are 9 medical schools that offer psychiatry residency programs, but they're not all equitable in terms of their resource allocation, their capacitation in terms of being able to train doctors who are specializing in psychiatry in the various subspecialties of psychiatry. So in South Africa, we also have subspecialties of psychiatry. So once you become a psychiatrist, you can specialize further in a subspecialty. And the subspecialties that are approved in South Africa, and they're also approved in other African countries, some of them, as well as in many other countries around the globe, are child and adolescent psychiatry, addiction psychiatry, neuropsychiatry, old age psychiatry, and forensic psychiatry. And the subspecialization requires an additional 2 years of training. So you become a psychiatrist and then you enter into 2 years of subspecialty training. I want to point out that it is important for medical students to think about psychiatry as a specialty. It's a very, very rewarding specialty to be in. But in addition to the rewards that it brings, it is important to know that most countries in Africa actually have less than one psychiatrist per 100,000 of the population. In fact, 3/4 of countries on the African continent have even fewer psychiatrists. So if you can think about a half psychiatrist per 100,000 of the population, many countries in Africa don't even have half a psychiatrist per 100,000 of the population. So it is really important that we think about producing more psychiatrists on the continent. South Africa is more privileged in terms of the number of psychiatrists compared to many other African countries, but it doesn't rank number one. In fact, it ranks number 4 in terms of the number of psychiatrists. So we have 1.52 psychiatrists per 100,000 of the population. And most of those psychiatrists work in urban areas. So the situation is much more dire in rural pockets in the country. So I said we're not the top ranked country on the African continent in terms of the number of psychiatrists. We rank 4th after Mauritius, the Seychelles, and Egypt.
Oh, wow. Okay, so that is quite a big distinction. I wonder why many people aren't going into psychiatry. In my personal experience, and currently in Zambia, I feel like mental health is still quite a big stigma. But also perhaps maybe people don't really know the difference between the psychologist and the psychiatrist. Could you share or enlighten us on the differences between a psychologist and a psychiatrist?
Yes, so a psychiatrist is a medical doctor, as I've just mentioned, who has specialty training in psychiatry. A psychiatrist is able to conduct psychotherapy, which is a form of treatment that is administered to patients with various mental illnesses, as well as to prescribe medications and other medical treatments like electroconvulsive therapy and transcranial magnetic stimulation, and many other interventions. So because they are physicians, psychiatrists can order and perform the full range of medical laboratory and psychological tests. And their education and their clinical training equips them to understand the complex relationships between, emotional and other medical illnesses, and the relationships with genetics and family history, and to be able to evaluate medical data and to make a diagnosis and develop treatment plans. A psychologist has an advanced degree, and their advanced degree is in clinical psychology. So they have extensive training in clinical practice in treating mental disorders with psychotherapy. And they also have specialized experience and training in psychological testing and evaluation.
Okay.
So psychiatrists and clinical psychologists work together. And that's one of the rewarding aspects of specializing in psychiatry. You work within a multidisciplinary team. And so it is a very rich experience when managing a patient, because you engage on a daily basis with clinical psychologists, with occupational therapists, with speech therapists, with nursing staff, psychiatric nursing staff, as well as several other members who make up that multidisciplinary team.
Yeah, it sounds like everyone needs to work hand in hand to ensure the overall well-being of another person, which is really good as well. So Professor, how do you handle, or how does one as a society, so I've already mentioned that I feel like in Zambia, currently certain aspects of mental health are very stigmatized. So how do we raise awareness and how do we handle the stigma of mental health?
Well, I think that we need to start with ourselves. And when I say we need to start with ourselves, I am also referring to ourselves as clinicians and psychiatrists, because psychiatrists can also contribute, mental health professionals like psychiatrists can also contribute to the stigma of mental health. And we can do that if we have self-stigma. And the way we can address that is to think about mental health as being part of overall health. To be able to talk openly about mental health, because when we keep it hidden, that contributes to stigma. So we can encourage each other, because mental illness doesn't discriminate. As health professionals, we are also vulnerable to developing mental illness. And so it's important to talk about our experiences of mental illness. Coupled with that, I think we need to educate ourselves as well as to educate others. I think we all need to make it our mission as health professionals to take every opportunity to educate people about mental illness. To explain to people, and by people, I'm referring to our family members, people in the community, our colleagues, that mental illness shouldn't be associated with shame and with guilt and with embarrassment. I think we also need to be conscious of our language, because language matters so much. It's easy to refrain from using mental health conditions as adjectives, and that's what we need to do. We need to stop talking about individuals as being schizophrenics or bipolar, a bipolar person. Rather, it is a person with bipolar illness, because language can be hugely problematic. Then I think we also need to play our part as clinicians, as medical students, in encouraging equality between physical and mental illness. That's so important. We need to make sure that people understand the true facts of mental illness, because when they realize that it's a disease, that mental illness really constitutes brain disease, these are brain circuitry disorders, they often think twice about making derogatory comments about mental illness. So remind them that, they wouldn't make fun of someone with diabetes or with hypertension or with cancer or heart disease. So why make fun of someone who has schizophrenia or bipolar disorder? Then I think we also need to kind of look within ourselves and think about compassion and empathy. We need to show compassion for those with mental illness, because mental illness is a disease. And so I think we need to kind of look at our own humanity. We need to look at the humanity of those who are suffering from mental illness. And so, it's also about empowering our patients and getting to empower them over the shame that they may be experiencing. We also need to be honest about treatment for mental illness. So while we have effective treatments, they're not optimally effective in every patient. And I think we need to be clear that there is still some way to go in finding more effective treatments. And I think we also need to let the media know when they're being stigmatizing, because the media plays such an important role. And that's mainstream media, but also social media. So we need to call out individuals who are stigmatizing mental illness. And then I want to go back to self-stigma, because we need to make sure that we are not ourselves stigmatizing mental illness. And we can do that inadvertently. It can be very subtle. And we need to, I think, always be mindful of our behavior and the way we speak about mental illness.
Very true. I think those are very important aspects. So I think we need like a printout just to remind ourselves on a daily, because I think it's easy to forget to look after ourselves, even as medical students or physicians. So you've already touched on bipolar and schizophrenia as more of adjectives to describe people, but can you tell us a little bit about the differences between an actual bipolar or an actual schizophrenic case?
Yes, so bipolar disorder is a mood disorder. So it is categorized as a mood disorder in our categorization of mental conditions. Schizophrenia is categorized as a psychotic disorder. And, while that is well and good for a clinician, I think in terms of understanding the difference, we need to know how these conditions actually manifest. So how do they manifest in a patient who has, either bipolar disorder or schizophrenia? So a patient with bipolar disorder typically has dysregulation in their mood state. And so they will have episodes of mania, typically interspersed with episodes of clinical depression, often very severe depression. Now, during a manic episode, a patient usually has a very expansive and elevated mood, which in children and adolescents may actually present as marked irritability. So a patient with bipolar disorder may present with a persistent elevation in their mood. They appear to be excessively happy. That's where the term manic comes from. They tend to be overactive, highly energetic. They tend to engage in goal-directed behavior that has the potential for quite disastrous consequences. So they may go on excessive gambling sprees or drinking sprees or spending sprees. They tend to require very little sleep. They speak very quickly. They're over talkative. They tend to have a flight of what we know as a flight of ideas, where their thoughts are very rapid. Often they don't make much sense. They have inflated sort of self-esteem, and they can be very grandiose and even religious. So a patient with bipolar disorder may think that they are God, or they may believe that they're someone famous, or they may believe that they're a member of royalty. And in that manic state, that patient or that individual truly believes that they are someone really important. These patients are often disinhibited during a manic episode, so they may undress, they may come across as being behaviorally very inappropriate. And so because of this cluster of symptoms, a patient during a manic episode can be very disruptive, and it may be really difficult for a spouse or for a family to contain such a patient within the home. And it's often these patients who need to be taken to an emergency center, to a casualty setting, to be assessed, and they're often admitted. And in many instances, they're admitted against their will, so involuntarily, in order to prevent them from self-harm as well as from harming others. Because during a manic episode, an individual can be so energetic, they may actually lash out, they may display, as I've said, disinhibited as well as aggressive behavior. Now, schizophrenia is, as I've said, a psychotic disorder, and so it's characterized by psychotic symptoms where the patient actually distances themselves from reality, and that's not intentional. So there is an altered experience of reality. And during an episode of psychosis in a patient with schizophrenia, when they lose reality, they actually see the world in a very distorted way. So what they experience are hallucinations often, where they hear voices or they see things that aren't there. They experience delusions, and these are like firmly held beliefs that are not supported by objective facts. They often become very paranoid. They think that others are out to get them. They believe often that the television or radio or the internet are broadcasting very special messages for them. Their thought processes become very disordered, so they may have very disorganized speech, and to you or I, that will come across as being very incoherent. We think that this person is really speaking nonsense. They have no control over this. They can also have negative, what we call negative symptoms, where they lose motivation, they become disinterested, they lack enjoyment in their daily activities, they become withdrawn, they will isolate themselves, they will show no emotion. So their faces and their facial affective expression is essentially flat, even the tone of the voice may be flat. They may speak far less. Sometimes they become mute. When patients are very, very ill, they can become mute. And they can also have problems with thinking and with concentration and with memory. So it is a very serious illness, and we refer to both schizophrenia and bipolar disorder as being serious mental illness. And many patients with schizophrenia have an onset of illness in teenage years and early adulthood. And that affects their social, their occupational functioning, their interpersonal functioning, the way in which they engage with family members. So it can be a devastating illness. And that is why for both conditions that you've asked about, early identification and treatment are key.
Yeah, that definitely makes sense. Are these two conditions, I know they're just a handful, or they're just two in the myriad of conditions that are psychologically like diagnosable, are they very common in individuals, would you say?
Well, they have a prevalence. They are common. If we think about the prevalence of schizophrenia and bipolar disorder on average of between sort of 0.5 to 1%. And if we sort of try and quantify that differently, that means that 1 in 100 individuals will develop either bipolar disorder or schizophrenia at some time in their lives. And you know, that is a prevalent condition. Both schizophrenia and bipolar disorder would, you know, be considered to be prevalent based on the figures that I have just mentioned.
Yes. So based on my understanding of psychiatry being a specialist, how would one actually go about making an appointment, and then actually, because it's quite a prevalent condition within society, how would one actually go about making an appointment or finding out how to get treatment should they suspect something?
So I can tell you about the referral pathways that exist in South Africa, but I want to preface that by saying that not only in South Africa, but on the African continent, and this is based on good data that we have from many countries in Africa, and data that the World Health Organization has been collecting for many, many years, and from the Global Burden of Disease study that has been in existence and being led by the University of Washington. We know that most patients with mental illness don't in fact receive treatment, that in, you know, the field of mental health, so on the mental health landscape, we have this really unfortunate state of affairs that 76 to 85% of people with severe mental disorders like schizophrenia, like bipolar disorder, do not receive conventional medical treatment. Many of them will receive treatment through non-conventional means, and we know that on the African continent, many patients will seek treatment from traditional healers, other complementary and alternative practitioners. But to get to your question about the referral pathway, most patients with mental illness will first seek treatment from a primary care provider. And typically in South Africa, those are from sort of community primary care clinics. So a patient would visit a community clinic in the area in which they live. And this is more challenging in rural settings where patients may have to travel long distances to get to a community clinic. And those community clinics are typically staffed on a daily basis by a nurse, often a psychiatric nurse or a general nurse who has advanced psychiatric training. And doctors, so psychiatry registrars and specialists, will visit the clinics, you know, once a week, often once every 2 weeks. And so most patients don't have access to a medical doctor. And depending on the severity of illness, a patient may then be transferred to the nearest district hospital for further evaluation and admission. So I'm based at a tertiary academic hospital. And so we see very severe and complicated instances of mental illness, mental disorder. And so very few patients are able to access a tertiary academic setting because we have a huge pressure on beds. And this is a very similar situation, you know, throughout Africa, that we have a huge pressure on beds. And so many patients are just not admitted despite needing inpatient admission, evaluation, and management.
Okay, thank you. So, Doctor, we've already spoken about bipolar and schizophrenia. So there's one topic I think that majority of people as well can relate to, especially on social media or TV shows that portray this, and that's the topic of, well, depression and suicide. So can you enlighten us on the risk factors for suicide or identifying individuals at risk, and what can we do if we know someone that could be at risk?
So thank you for the
suicide.
question, because thank you for the question. Suicide is a global health priority, and in Africa, we know that approximately 35,000 suicides take place annually. And suicide is more common in men than in women. So worldwide, 3 to 4 more men die by suicide than women. It's a multifactorial problem. It's a multifactorial issue, suicide, because it involves a very complex interplay of biological, psychological, cultural factors. And, you know, you asked about the risk factors for suicide. How do we identify individuals at risk? So let me start off by saying that it's important that we know and important that I, as psychiatrist, know that primary care providers have a really important role to play in suicide prevention. And so equipping staff who work at community level to identify individuals who may be at risk of suicide is hugely important. Because among people who die by suicide, more than 80% have actually visited their primary care provider in the previous year. And half of them, 50% of them, have actually visited a primary care provider in the previous month. So most individuals who are suicidal do not access psychiatrists. They don't seek care from a psychiatrist. They actually seek care from a primary care provider. So one of the most robust risk factors for suicide is a previous suicide attempt. So in an individual who has a previous suicide attempt, one has to have a very high index of suspicion and exercise caution, because that individual is at a much higher risk of successfully dying by suicide. Then a history of mental disorder. We know that depression is one of the mental conditions. In fact, it is the mental condition that has the highest association with completed suicide. So a history of mental disorder, depression, but any other mental disorder is a risk factor. Alcohol as well as drug abuse is a risk factor. So an individual has a history of alcohol or drug abuse is at higher risk of dying by suicide. Having physical illness, especially if it is a terminal illness like cancer, can also put someone at a higher risk of suicide. Social isolation is a potent risk factor for suicide, particularly in males, middle-aged males who are living alone, who have feelings of hopelessness about the future. And then we know that easy access to lethal methods like firearms is also a risk factor. And that's really important, because On a public health level, if we want to reduce suicide, the two most effective ways to reduce suicide to make sure that patients have access to antidepressant treatments, because if depression can be treated, we can substantially reduce the risk of suicide. The second very effective way of reducing suicide on a public health level is to ensure that we can reduce access to the means for suicide. Now, on the African continent, the commonest ways in which suicide is effected is through pesticides, so poisoning, through hanging, through firearms, and through drowning. And that's important to think about. So you asked me about the risk factors, but when we think about risk, we also have to think about what can buffer risk. What are the protective factors? And the number of protective factors. So having a stable support system is really important. And so we can think about that in the context of a patient who may have suicidal thoughts, who may have even developed a plan for their suicide. If they have a stable support system, you can mitigate that patient's risk. If an individual has a stable employment, income, that also is a protective factor. It buffers a person from a successfully completing suicide. Another factor is cultural and religious beliefs. And we know that on the African continent, that is so important. So individuals who have strong cultural and religious beliefs, and especially where cultural beliefs discourage suicide, that is a protective factor. Now, how can you identify warning signs? So I've mentioned some of them. I've mentioned the isolation. Someone is isolating more, if they're expressing feelings of hopelessness on a regular basis, if they are saying that they feel trapped, if you have a patient who is increasing their substance use, if they are making concerted efforts to gain access to, say, a firearm or poisoning, if they have extreme mood swings, if a person is starting to make plans for suicide, like starting to give away their prized possessions in a very uncharacteristic manner, or if they're starting to act really recklessly, or if they talk a lot about suicide, especially on social media, those are warning signs and they have to be taken really seriously.
I feel like I've had the unfortunate time in my life where I've known people who have committed suicide. And I think it's very easy for like someone who's studying medicine to say, how did I not pick this up? But can you maybe give us some guidance on actually how to support someone, a loved one, a friend, more effectively? Because I feel that many people also don't go out and seek help. So when they do have when they do reach out, are they necessarily reaching out to their loved ones? Are they reaching out to a psychiatrist, a psychologist, a counselor? So if I, for example, know someone, if I see warning signs in someone, how can I, as Anya, effectively show them support without necessarily smothering them?
So I think it's important to ask. It's important to ask a person about suicidal ideation. And I think that's where we often sort of shy away because it may be embarrassing, or we want to be mindful of the other individual's privacy and keeping, their thoughts and their feelings to themselves. But it's important to ask. You can ask the question, are you thinking about killing yourself? It's not an easy question to ask, but we know that studies show that asking at-risk individuals if they are suicidal does not increase their risk for suicide, or it doesn't increase the suicidal thoughts that they are already experiencing. Then we need to try our best to keep them safe. So, and as far as we can, to reduce that person's access to highly lethal items, or ensure that they are being supported, that they have people around them that will actually disable their plan to access, the lethal means in order to take their own lives. Then just being there, I think, listening carefully, learning about what the individual is sort of feeling and how they're thinking, acknowledging that talking about suicide with them can actually decrease their thoughts. So I think if you share that with the person who's experiencing suicidal thoughts by saying, I'm talking to you, I'd like to hear how you're feeling, how you're doing, why you have, been thinking so much about taking your own life can be hugely helpful. Then I think helping them to connect. And, there are a number of sort of lifeline, helpline, hotline numbers in many countries. So the International Association for Suicide Prevention actually has a database of international resources, including helplines in many countries in Africa. In South Africa, for example, we have the South African Depression and Anxiety Support Group, and they have a suicide hotline, a 24-hour hotline, but there are many other African countries that have similar hotlines. So then I also think it's important to kind of just stay connected with the person, make sure that, we stay connected with them, that we don't judge them, that we kind of just listen to them, that we don't minimize their problems, we don't try to convince them that, it's not that bad, that their problem or their situation is not that bad, because you're trying to, essentially kind of undermine what they're experiencing. And don't preach about suicide being right or wrong, even if you have personal, ideologies around suicide. It's not a good idea to share those with a person who is suicidal.
That's wonderful. That's actually really helpful. Prof, just another question following that. I feel like, because I've had a conversation personally with someone that has expressed wanting to commit suicide, but I feel that afterwards there's a lot of shame that comes with it. Do you not think that that might affect the relationship and then them not, opening up again, or being so shameful that they just distance themselves even more? Or is that just a unique experience in some cases?
Well, in the moment and in the kind of period, let's refer to it as the episode in which that individual may be experiencing very strong suicidal ideas, especially if that individual has suicidal ideas in the context of depression, in the context of a major depressive episode. They are feeling hopeless. They are feeling deep emotional pain. And depression is characterized by feelings of shame and guilt. And so one needs to think about the way that, they are experiencing that moment in time, and, your relationship with that individual. Because yes, at that moment in time, that individual may feel so shamed by what they're experiencing, and they may be more inclined to kind of withdraw and not to communicate with you. But at another point in time, once that individual has received support and help, it is highly unlikely that your relationship with that individual is going to be impacted by this episode, because I think, at that point in time, the individual will be able to think more rationally about that experience. And you'll be able to talk, I think, in a different way than you would have with that person, in that moment of acute emotional pain.
Thank you. I think that's definitely very helpful. So we've already touched about specifically suicide that we should keep an eye open for. Sorry, Dr. Akwi?
Anna, go ahead. You froze for a quick second.
Okay, sorry. Yes. So how do you think with the effect of lockdowns and COVID-19 and having to, be isolated, and unfortunately some people are forced to stay by themselves, how does that affect their mental well-being, or what is the effect, the psychosocial effect of the pandemic on the public, but as well as healthcare workers? Because I think physician suicide and physician burnout itself are quite a prevalent case, regardless of the pandemic.
So thank you for the question. In many ways, the experiences of the general public mirror what healthcare professionals are experiencing. At the same time, there are unique experiences that frontline workers and healthcare professionals generally are experiencing that the public is not exposed to. So we know from previous pandemics, the previous SARS pandemic, the H1N1 pandemic, Ebola, that quarantine has many negative impacts on mental health. The social isolation, the sequestering of individuals, the economic impact, the kind of breakdown in terms of academic pursuits have all had a negative impact. And we know that from previous studies that in terms of the general public, this results in high levels of psychological distress, anxiety, depression, post-traumatic stress. Now, couple that with the COVID-19 pandemic, which has been characterized by unpredictability, chronic stress. So in South Africa, we're currently in the least restrictive period of lockdown, level 1, but we've been in lockdown since the end of March, and many people are feeling very, very frustrated. So healthcare workers, have had additional burdens to have to contend with. They've been faced in many different ways with a feeling of impotence because the way in which this pandemic has played out medically, as a multi-system disease has also been really unpredictable. Many patients who were, thought in an ICU or, on a ward that managed COVID patients to recover actually died unexpectedly. And so, it's a sense of impotence that healthcare workers have been experiencing. It's the fear, it is fear of the unknown. And so it is really important, and this is what I think there have been many concerted efforts around the world to do, is to try and ensure that we engage with healthcare workers and that we find ways to prevent these adverse mental health sequelae from occurring, because previous pandemics have shown that 2, 3, even 4 years after those pandemics, healthcare workers who were on the front line continued to experience many adverse mental health outcomes, depression, post-traumatic stress, burnout. So prevention is so important, and that has taken sort of the form of psychological first aid, which is really practical emotional support to individuals on the front line, really teaching healthcare workers who tend to put the health of others before their own, that it is really important, in fact critical, that they manage their own stress and psychological well-being. And that's as important as managing their physical health. That means just taking care of really basic needs: nutrition, sleep, employing very helpful coping strategies, making sure that they get enough rest between shifts, staying in contact with family or friends, staying away from misinformation, which of itself can be hugely damaging in terms of emotional well-being. So stress-related interventions, trying to bolster resilience of healthcare workers. And many of those same strategies are also very effective in the general population.
Mm-hmm. Oh, sorry, I think I froze there for a second. Okay, there we are. So I think that's, yeah, especially knowing the stress and everything that comes with just having to be on the ward and seeing patients, even as a medical student, it's just honestly so tiring, and we put so much pressure on ourselves. And I think the frontline workers put extra pressure on themselves as well. So that might perpetuate the whole mental health, like not necessarily looking after oneself to make sure someone else is looked after. So yeah, I think thank you so much for this topic. Prof, before we end off, because we're already nearing our hour, I just wanted to ask you, are there any platforms that you can give us to find help anonymously? You've already mentioned the South African Depression and Anxiety Group in South Africa, but if there are any ones that we can maybe note down so we can, you know, have a way that we can find help anonymously, whether in South Africa or abroad, if you could share that for us.
I want to just ask you, Anya, are you asking specifically about COVID-19 related mental health resources or mental health resources more generally?
I think more generally, but if you have one specifically for COVID-19, I think that would be very beneficial for our South African market, especially knowing, because I was in South Africa until the borders reopened. So I went through the whole lockdown, level 5, 4, 3, 2, and then finally October happened. And I volunteer at the South African Depression and Anxiety Group, so I was kind of involved with that. And I know that the effect of, oh, and then now coming back to Zambia, and Zambia is completely open. So the advice or anything that can help someone in South Africa find help for mental health, for stress, for anything, specifically to the pandemic, would be amazing for the South African audience. But then if you know anything in specific for the general public abroad, we would be very grateful if you could enlighten us.
So Anya, I'd be very helpful to share the link to my department's website, where we have a COVID-19 tab on our website with a host of resources for the general public, but also for health professionals, informational resources, but also contact resources. There are also a number of mobile apps for the public, and there are a number of COVID-specific apps. So for example, there is an app known as COVID Coach, which is freely downloadable on Android and iOS. And it is an app that you know, has stress management techniques, so relaxation techniques, mindfulness-based techniques. It has other kind of information on COVID. And there are a number of other mobile apps that could be very helpful during this time. And I'm happy to send that information to you, and perhaps you could distribute it to anyone who is interested.
That would be wonderful. I think, yeah, Dr. Akwi will probably get in touch with you with regards to that. I've just got a question here from the audience as well. If maybe you can just comment on the topic of mindfulness, and then we can maybe wrap up.
So mindfulness-based interventions have gained traction in the mental health field, in psychiatry more broadly, for the last 10 years or so. And we know that mindfulness-based techniques have been in existence for a long time. And mindfulness techniques, which really sort of teach a person to be in the moment, to really be present in the moment, have been shown in many randomized controlled trials to be very, very effective for a number of common mental disorders. And there, you know, is much research underway to test different types of mindfulness-based interventions. for a number of different common mental health problems. So mindfulness-based interventions are a modality, so they're kind of a basket of interventions in the same way that cognitive behavior therapy are a basket of interventions that have been shown to be effective for a variety of mental disorders. It is very important for any person who has a mental health problem to seek consultation and to get advice about the most appropriate psychotherapeutic intervention for them and for their condition, because as with mindfulness-based therapy, other therapies don't work for everyone and for every mental health problem. And often these psychotherapies have to be administered by a clinician, by a mental health care provider, alongside a medication intervention. So they're often used as an adjunctive treatment to medications. But I just want to emphasize that it is really important for any person who's experiencing mental health problems to first be evaluated and to get advice on the most appropriate intervention or interventions for them and for their condition.
Thank you so much. Prof, I think this has been, very, very informative. I think as we were sort of planning and discussing this, and I gave the example of this, fly I'd seen where it says it's okay to not be okay, and I think, like you've, pointed out in this conversation, mental health, is something we don't talk about. I think it's sometimes maybe, viewed as a sign of weakness. And we appreciate some of the comments being made of, people, sharing their stories about mental health and the platforms that they have for mental health, So your points are very much appreciated. We really appreciate your time. And as anyone, everyone who's out there listening, I think some of the key things that she's mentioned is it's okay to talk about it, get help. It's okay. I would like to thank you, Professor Siddharth, for your time. Thank you, Anya, so much, for the conversation. We truly appreciate you, Professor, for coming up on a Saturday to talk about this very important issue. We've typed in, to the group in terms of some of the, apps you mentioned, but I think one of the key things is, it's not only about the app, it's about talking to someone, find someone you can trust. We need your voices, we really do. So, and on that note, I would like to wrap the session up. The session has been recorded for anyone who would like to listen to it later. On behalf of the Pan-African Organization for Health Education and Research, we very much appreciate your time, Professor, and have a great day. And to everyone watching, have a wonderful, wonderful day. Anya's mic and video sort of went off, and so she apologizes for suddenly dropping off. But she also personally thanks you for your time and for all the resources that you shared with us. So thank you so much, Professor.
Thank you so much for hosting me.
All right. Have a great day. And to everyone who's watching, good morning, good afternoon, good evening. Have a wonderful and hopefully relaxing day. And we'll catch you at the next event. We'll be talking about breast cancer awareness. And watch the page for more details. Thank you. Ending now.